Thank you for having me. I'm so pleased to be here. I'm going to talk a little bit about Centerstone Research Institute, which is the organization I run, which is part of a larger system of care, Centerstone. In my bio, it talks about how this came to be. I want to just tell you, though, the things that we'll show you that we're doing is atypical for behavioral health care, particularly in the United States, and even for a lot of medical surgical interventions. Is the term behavioral health care familiar to you? In the States, that's a term that is an encompassing term meaning mental health, substance use disorders, and psychiatry. It's kind of a catch-all. So that's what I'm talking about when you hear me talk about that. It's kind of nice to kind of go at the end of these things because I've been privileged to hear the other speakers talk about things that are exactly the same problems we're dealing with in the States with our EHR implementation, but it's a very different paradigm. The government effects are similar in the U.S. As Dr. Chilvers has said, it is incumbent upon all of us to be sure that we inform decision makers about the importance and relevance of electronic health record systems. We have some examples of predictive modeling that we're using within our system that I'd like to show you if we have time. Professor Majid did a good job of talking about the importance of the data and how much you can use it, and I'd like to show you what we're doing. We've recently experienced some significant flooding in Nashville, Tennessee, which is where 70 of my 85 employees reside. They called this the 1,000-year flood. It literally was a devastating flood. So that and the oil spill in the Gulf in the United States have made me acutely aware of meteorological issues. So for Ms. Barber, I want to thank her for her contributions. One of the things we mentioned, she and I talked about briefly, was that the things that are coming that nobody talked about is that the statistical and analytical tools used in meteorology will ultimately be ported over to healthcare because we will have robust enough data sets but complex enough systems that we will need those kind of sophisticated tools. And I think some of the things that we're doing with predictive modeling is a start in that. Could I pose what you, yeah, glass of water. The confidentiality issues that you have here are quite a bit different than the States, particularly for behavioral health care. Thank you. One of the things that I can't remember, I think it was Mr. Duddy that mentioned this. He didn't put it this way, but my belief is that when you automate a mess, what you get is a very fast mess. So I would suggest to you that one of the key factors you want to do before you ever go down the path of an electronic health record is to flowchart every system in your organization. And I know that sounds like an incredibly taxing challenge, but if you don't do that, you will then be automating systems that are inefficient in a paper record system. And you will find dead ends and things you just will never, we'd be completely surprised about why and how you're doing things at all. There's also this phenomenon of terminal uniqueness. We all think we are so different, and in fact we aren't. It's interesting, Ms. Barber and I talked about that, and she said she gets that in meteorology, where a small town will say, oh, we have a microclimate here, and it's 5 miles away from another town. It says, oh, ours is different here, and that can't be true. And Dr. Morrison's comments about the emergency care summary is very similar to an initiative in the States called the Continuity of Care document that we're working on for very similar reasons. As I mentioned earlier in some comments, the U.S. is banking on a standards-based integration system where we standardize on the data systems rather than on the platforms themselves. And if we can transact data, then it doesn't matter what kind of platform it resides on. We're similar in many ways, as I've learned today, but in fact we're very different, and I'm going to talk about that in just a second. I would suggest to you that there are two key factors for a successful implementation of electronic health records, and they are leadership and workflow. If you get those two things down, you will have you have a high probability of success in your implementation. Without leadership, without someone to say, this train is heading north now, we need to be on board that train, we're going to change the way we do things, and here's why, you will not be successful. And if you don't do the workflow analysis, as several of the speakers have mentioned, and identify how it is that things work in your organization and make it flexible for the clinician to use, you're going to have significant problems. In actuality, this is really a change management process at its core. when you talk about changing to electronic health records, it's no different than changing anything else big in your organizations. And when you look at the change management literature, there's lots of things that you can look to for success in that area, in those areas. I have two general suggestions for you as you think about implementing your electronic record system. One is the flow charting one. Flowchart all processes in your organization to identify dead ends. And the second is particularly those of you who are in leadership positions. Who might that be in this room? Who in here has a leadership role somewhere in your organization relative to there's only 3 leaders in this room. Amazing. There's a lot of people who don't like commitment. The other, particularly for you, but for all of us, but particularly for the leaders who are going to be providing information about electronic health records, go into Microsoft Word and change the autocorrect feature so that EHR does not become HER. Your credibility will be lessened significantly if you type, we're going to do this HER tomorrow, and the memo goes out and people say, what? We're doing her? Who's she? What? We're doing? So let me press ahead here. As Yogi Berra said, I didn't really say everything I said. I'm hopeful that won't happen to me today. Centerstone Research Institute is a private nonprofit organization similar to an NGO in your country. We formed as a result of a merger of 4 mental health centers, 3 other mental health centers besides my own. We combined all the information technology and research assets and put them into a new company, and that's what I run, and that is Centerstone Research Institute. We're not a provider organization. We see no patients, but we do clinical research and information technology, and it's not coincidental that those two things are together, because we believe that the goal is to build electronic health records that inform clinical decision-making using research data to provide contextually appropriate data for the clinician that's relevant to the client sitting in front of them. And you can only do that if you have both the research and IT side together. We provide all the IT support for the whole company, and we have a company called Behavioral Pathway Systems that provides benchmarking data throughout the United States virtually. When you think of a scientist, that's kind of what we are. This is what typically comes to mind, but we tend to see things a little bit differently. My executive assistant photoshopped Albert Einstein's head on my body. So the ultimate goal for Centerstone as a corporation is to prevent and cure mental illness and addictions. And that might seem rather bold to talk about prevention and cure of mental illness, but I can tell you our belief is that if someone around Jonas Salk's time had not started talking about a cure for polio, we would all be in the business of making better and better iron lungs. And so the time has come, I think, for us to talk about that seriously, especially with the work that's being done in genetics and other implementations for pharmaceutical interventions and others. I think we have a chance to do that. My part of that business is to advance the science of care. So when I think about preventing and curing mental illness, this is what I think about. The history of mental health treatment in the United States has not been kind. We are far beyond that today, although in some quarters one would argue that the deinstitutionalization that we've been successful with in the United States has served really only to provide in loco parentis institutionalization of people with serious mental illnesses in their communities. When I think about advancing the science of care, however, I think of this. It's a screenshot from our electronic health record. All of these are treatment interventions that are currently in play or being implemented. Vagal nerve stimulation, transcranial magnetic stimulation, deep brain implant. This graph up in the upper right-hand corner is one of those that, if I have time, I'll show you, that's from our predictive modeling. But ultimately, genetics is going to be the big future for us, we think. When you look at the effect of mental illness in healthcare in terms of the effect on society, in 2004, unipolar depression became the leading cause of disability in middle-income countries across the world. and in high-income countries. So of all the disease entities, depression is literally the highest and most significant impact on all societies.